So the next speaker for today's session is going to be Dr. Khalili, who is a radiologist from the University Health Network. He's going to talk about the utility and nuances of total kidney volume measurement. Welcome.
Thank you so much, York. It's always a pleasure to be here at this conference, and I continue to learn a lot from the wonderful audience. And this year in especially, we have such a wonderful group of speakers. It's amazing. Thank you so much. I'm going to just get myself familiarized with our system here. Great. So my talk is going to be with regards to a number of imaging related topics. First thing I'm going to do is just briefly review the normal appearance of kidneys on the imaging, and especially just kind of go through the pros and cons of the different types of imaging modalities that we have, the common ones anyways. I will then talk about the typical and atypical manifestations of polycystic kidney disease, some of the imaging mimickers of polycystic kidney disease, and then the utility of total kidney volume measurements and how we actually obtain those measurements, and briefly also talk about ultrasound and total kidney volume, TKV. So here's the CT image of normal kidneys, or at least the left kidney here. Is it left kidney? No, right kidney. Excuse me, I'm looking at it backwards here. So here we can see the liver on top of the kidney, and this is an unenhanced scan on the your left side. So this unenhanced scan, we can see that the outline of the kidney and separated from the liver, but we don't see much detail at all inside the kidney. And the reason for that is because X-rays in general are not very good in differentiating the different types of tissues, other than whether or not it's fatty or contains air or contains bones. So if it's devoid of lots of very kind of hard minerals, then will appear very black, and if it's full of very hard minerals, will appear white, and if it's somewhere in between, it will kind of be a shade of gray. Now, for us to improve on CT imaging, we have to instill some hard, dense material, and that's the intravenous contrast that's injected. And patients, like to use the word dye. So it's the dye that's injected in relatively fast and hard volumes to be able to raise the density of any place in the body where blood flows. And so what we do in CT is we take this large volume of contrast and we inject it very quickly through a pump into the veins. And this bolus of contrast, large volume, goes through the cardiovascular system and flows first into the kidney in the renal cortex. And so we take a picture when we think that that's the usual timing around when the enhancement occurs, or the flow of blood goes into the kidney. So we time this, and that's called a nephrographic phase, the corticomedullary phase, or also called the arterial phase, so earlier phase of enhancement. And then we take a little bit of a picture, a little bit longer, and here we can see what's called a nephrographic phase, where the contrast is kind of work its way now from the cortex into the medullary, into the collecting system, and into the medullary regions of the kidney. And that's why its density kind of increases and becomes a little less visible compared to the background cortex. Now, with MR, we use an entirely different system of imaging, and what we're doing is we're looking at the small little magnetic fields that are produced by protons. And so we place a patient in a magnet, and we try to look at the alterations in the magnetic field that we create coming from the motion of the protons themselves. And so we can try to image all of the protons, and this is kind of the T1 weighted image, or we can try to direct our imaging to different, types of protons. And in this kind of image, the T2 weighted image, what we're trying to do is maximize the signal that we get from water. So really what we're looking at here is the relative presence of water in the different areas. And so we can see that, let's say in the spinal cord, there is the cerebrospinal fluid. So watery stuff will appear really bright. Some water in the bowel will appear really bright. And the kidneys are fairly bright organs because there's a lot of blood flow into them. And then we can see these little cysts that will stand out because they're full of water as well. So the T2 weighted image is generally what we use more to actually image the cysts within the kidneys. And if you click on this image here, now we can kind of see to some degree dynamically what happens when we inject the MR type contrast that you've heard this morning called gadolinium. And again, what happens is that the blood again goes through the cortex and then starts working its way down into the medulla as the contrast starts getting into the pathophysiology of the collecting system. And so these are the different phases when we kind of image them at different points in time. So I haven't shown you an image of ultrasound, but I will show you images of ultrasound. Everybody's quite familiar with it by this time. Usually in our lives, we've had multiple ultrasound scans. And if you're unlucky, like myself, you've had a CT scan or MR scans as our body and joints start giving us symptoms and pains and whatnot. So, in terms of being able to differentiate different types of tissue, and especially solid versus cystic, ultrasound is wonderful for that, and MR is wonderful for that. CT is not really so great, and that's why we really need the dye with intravenous contrast, and it does better with the dye. In terms of us being able to measure things, ultrasound is not so great, but CT and MR are very good because they show you the whole of the organ, the whole of the body, and you have these images that then anybody can access and reproducibly measure. In terms of contraindications for these different modalities, ultrasound has pretty much no contraindications whatsoever. CT and MR have some issues, and if part of it is because of the intravenous contrast that we inject, a part of it is because of some of the compatibility of devices and things that patients might have on them that might not be acceptable to go into this very strong magnet that MR has. In terms of the different body types of patients, so larger patients, ultrasound will have difficulty with, and it's because the sound waves are generated from outside and they have to penetrate through more tissue and they'll have trouble that way, whereas CT and MR do great that way. In terms of tolerance, patient tolerance, patients have no trouble with ultrasound and generally not much trouble with CT, although most patients don't like to have that injection. And with MR, though, you need to be in this strong magnet, and a lot of patients, some patients, let's say, are not great fans of getting in there, and so most people can tolerate it fairly well, but preference-wise, it's not something that people prefer. From a side effect point of view, they're all very, very safe. I should really point that out. But ultrasound has no issues in terms of side effects. CT scan, because it does use X-rays, we want to minimize the radiation exposure to patients. And MR generally also has very, very rare side effects with regards to the intravenous contrast if we're going to use intravenous contrast. And then availability, ultrasound you can find in every street corner to some degree. CT scan, not as much. And MR is kind of more restricted depending on where you live in the world. And cost-wise, that's also reflected. That's why ultrasound is so much more available. So we've seen this morning some images of patients with PKD already on MR and our CT scan. And so here is a spectrum of findings. We can see in younger patients, we generally end up seeing smaller cysts. And so here, 20-year-old female, this is a 12.5 centimeter size kidney, and that's just a little bit larger than what we tend to see in women at that age. But you know, sometimes patients can be very tall, and so this is kind of borderline in terms of the sizes. But you can see that there are all sorts of little cysts in there, some larger cysts, and there is black spaces in between the cysts, and that's going to be mostly a lot of functioning parenchyma. And then we can see quite a bit of different, you know, heterogeneity because of all the heterogeneity in the genetics that you heard about, and the manifestations and the mutations that we've heard about this morning. And that heterogeneity leads to having different types or imaging appearances. So this patient, for example, is 42 and has 17 centimeter kidneys, and there's some black spaces still between the cysts, whereas this patient is 30, so 12 years younger, but has larger kidneys, and we cannot see really any kind of parenchymal tissue on this, so this is more severe disease. And then we've also heard about milder forms of autosomal dominant polycystic kidney disease. And so this is patients with PKD1 mutations, that there is more function than the more severe type of PKD mutations. And so in this patient, for example, 24-year-old male, very lucky in the sense that we hardly can see cysts. They're just very pinpoint little cysts in the kidneys. This is a 61-year-old patient that has a few cysts, but these are large cysts, but they're few. And in between the cysts, we can still see some degree of kidney parenchyma. And so generally, they tend to have better kidney function. And in the same vein, the same thing with PKD2 type mutations, where again, younger patients will see more cysts than we would normally. But there is still quite a lot of non-cystic renal tissue. And here's a 51-year-old patient, and here a lot more cysts, but still there are areas in between cysts that seem to be maintenance of the renal parenchyma. Now, not only do we have patients with different types of mutations, but also there are atypical patterns in patients with even similar mutations, or mutations that only affect portions of the kidney. And so that disease heterogeneity is something that we see quite a bit with PKD. And so these are atypical patterns of autosomal dominant polycystic kidney disease, and I'm just going to go through some of the atypical patterns. So sometimes we see the disease unilaterally, so one kidney has no cystic disease, whereas another kidney has typical disease or multiple cysts. Sometimes we can see the disease asymmetrically, so both kidneys will have cysts, but one disease is very severely involved, whereas the other kidney just very mildly involved. We can have segmental disease, so that means that there are segments in the portions of the kidney on both sides that are affected with disease, and then there are other portions that are spared. And we can have lopsided disease, meaning that there are asymmetrical regions that really have very large cysts and really increase the volume of the kidney. But then there are areas in the kidney that are maintained and not enlarged at all. And so there is kind of an asymmetry within the different portions of the same kidney as well. So an important aspect of imaging patients with polycystic kidney disease is to make sure that they actually have polycystic kidney disease. And every year when we get patients sent to our clinic, there is a proportion of patients that on review, we recognize that in fact, this is not the typical polycystic kidney disease pattern. And then, we try to find out whether they actually have another genetic defect that can mimic polycystic kidney disease and give them renal cysts, or in fact, they have no genetic defect and they have other types of diseases or conditions that can mimic PKD. So one of these is autosomal recessive polycystic kidney disease, and here we often recognize this disease in patients in utero. So when patients go for, not patients, but pregnant women go for their anatomy scans around the age of 18 to 20 weeks, we start identifying changes within the kidneys. So sometimes this is recognized in utero or when the baby is born. And so here we have an ultrasound on a 7-day-old patient. And this ultrasound scan, we can see that there are changes in the renal medulla, but not so much in the cortex. And if you can click on the image, there's a little video, there it is. There's a little video here. And so this is in vivo, a little crying baby. I had my little transducer on it, and the baby was really crying very loudly because he didn't like the coldness of the gel, just like every other patient who complains about the coolness of the gel. And while he was screaming his head off at that point, I managed to kind of catch these images, and you can see that the cystic disease in the renal cortex, there's hardly any change whatsoever, but what we see are these elongated tubular structures within the renal medulla. And so this is really not so much cyst as enlargement of these the renal tubules within the medulla. And so if you click one more time, I think we were very sensitive to the crying baby, and the resolution that ultrasound can afford you, if you can get close enough to the kidney, is incredible. And so those of you who do research and those of you who are involved with renal transplantation and whatnot, where ultrasound can actually get fairly close to the kidney transplant, we can see the degree of detail we can see is incredible. And very often we're seeing sub-millimeter abnormalities as well. So if you click on one more time, it doesn't like the next image maybe. Okay. Well, that's okay. If you can maybe go to the next slide, you might want to, I don't know if you have to close it and go to the next slide. While we're waiting for the images to come up, does anybody have any questions for me at this point in time? Oh, it is. We're going to back next one. Okay, wonderful. Thank you. So we have another movie clip now. This time, sometimes patients with autosomal recessive polycystic kidney disease have very little renal manifestations, and so these patients might be the disease might be actually picked up at a later age, and rarely we actually make the diagnosis primarily based on the manifestations in other organs. And so here, this is a patient, 19-year-old female. And again, what we see in the assessment of the kidney, if you can kind of run the video one more time, is that we start seeing some cysts and calcifications. It doesn't seem to like my videos. cysts and calcifications within the medulla, just like what we saw in that little baby, with relative absence of cysts in the renal cortex. And when we do MR imaging, the other images that's going to show up on these patients, if you, yes. Okay, so that's okay. We can go on to, we're gonna, yes. So when we do MR images in these patients, then we can see that the cysts are actually predominantly centrally within the kidney. And then there are different types of manifestations outside the liver, and this case, outside the kidney. And in this case, we can see there are changes within the biliary tree, and these changes resemble the disease that we call Korosh's disease. And so this patient has a Korosh's disease or Korosh's syndrome type appearance. It's not a classical Korosh's, but it's fairly okay for it. And so this is a patient with minor, minimal cystic disease within the kidneys, and we don't want to mistake this for PKD. Let's go to the next image. So another disease that can have renal cysts is von Hippel-Lindau disease. And with von Hippel-Lindau, commonly we can see cysts within the kidneys, but also solid renal masses, which are renal cell carcinomas. So I would say probably once every other year, we make a de novo diagnosis of von Hippel-Lindau on imaging, depending on which organ it's involving. But in the kidney, but usually it's based on the renal manifestations. We see a patient with multiple renal cell carcinomas, solid renal masses, but then sometimes we can see cysts within the kidneys, and we can see other cystic tumors elsewhere. So here is almost diffuse replacement of the entire pancreas full of cysts. So they can get different types of tumors within their pancreases, including cystic type tumors such as serous cyst adenomas. And in that patient, the entire pancreas was replaced with serous cyst adenomas. Another tumor, another syndrome that occasionally mimics PKD is tuberous sclerosis complex. And so with tuberous sclerosis, generally we end up seeing lots of fat containing nodules and masses within the kidneys, and fat on ultrasound will appear this, bright, and bright we call echogenic. So we see lots of little echogenic foci here, and then occasional cysts as well. Here's an MR in this patient, and then occasionally though we can see enlargement of the kidneys with lots of cysts. And so on occasion the kidneys will become really large, full of cysts, and can mimic polycystic kidney disease. This patient on this side looks like PKD kidney, but on this side, fat-containing tumors within the kidney, and the presence of fat tells us that these are angiomyolipomas or pecomas, and the type of tumor that we end up seeing with tuberous sclerosis complex. So non-genetic diseases that can mimic PKD. So patients with chronic kidney disease will end up having atrophied kidneys, so small kidneys as opposed to enlargement of the kidneys, but we also can see they acquire cysts. And so this is called acquired cystic disease of the kidneys, and we end up seeing these patients with chronic renal failure, this patient specifically with diabetes as well. And one thing I want to say to you, and this is an interesting area, is that development of cysts is actually normal part of human aging. So I'm on the wrong side of 50, and if you scan my whole body, you will actually see that I will have had cysts. Now I have cysts probably in my kidneys, in my liver, in my pancreas, and other parts, and so just like I tell patients and and some of the trainees, just like the fact that if I look at my skin, I'll start have now these nice little spots here and there, some growth and some changes in my skin. We'll actually see the same inside the body, and so so sometimes there is proliferation of cysts more than usual. And then this can also be mimicking patients with polycystic kidney disease. And so normal renal function, no family history of cystic disease, no mutation, but just prominence, multiple prominent cysts. Why does that occur? I don't know. It's very interesting, I think. This type of disease we could see at least once or twice, and Dr. Pei usually just picks these up right away and asks me to confirm it, but he doesn't need me. He's usually very good himself, just looking at the images and picking out the this type of disease, which is a congenitally kind of obstructed outflow from the kidney. So the ureteropelvic junction, UPJ, or pelvic-ureteric junction, PUJ, depending on the time that you grew up in. Those terms are both used. So this leads to dilatation of the collecting system. And so we can see that this can mimic cystic disease within the kidneys. And there is a little video clip. I'm not sure if it's going to work or not. Yeah, if it works. So here in these patients, we can actually determine whether or not this is functionally causing diminished function in the kidney or diminished excretion from the kidney. And in fact, a lot of times it doesn't. These are dilated collecting system, but there is symmetry in terms of the function of the kidney. So just dilated collecting system without actually affecting the excretory function of the kidney. Another mimicker that we see also one or twice a year, some patients sent to us with possible PKD are these very prevalent, commonly seen parapelvic cysts, and these are entirely different origin type cysts than the ones that we see in the renal cortices or elsewhere in the renal parenchyma. And these are very common as well, and they tend not to have any symptoms and cause any obstruction, but they can also mimic polycystic kidney disease. Good. So now that we've reviewed potential mimickers, now I'm going to talk about total kidney volume, and you've heard quite a lot about TKV already this morning. So TKV has diagnostic and prognostic value. Especially when we adjust the kidney volume for height and age, then we can use this age-adjusted and height-adjusted total kidney volume as a biomarker for disease progression. Okay, so it's a biomarker of disease progression, and it's more sensitive than actual renal function in terms of determining how the kidney will perform down the line in the future. And so then we can use that kidney volume, that height-adjusted, age-adjusted total kidney volume to determine whether or not we should start therapy in patients and use it as endpoint for trials as well. So how do we measure the total kidney volume? There are different methods that I'm going to go through now. But before I do that, this is a classical slide from an excellent study that came out about 10 years ago or so. And here, just to emphasize the role of total kidney volume, this is height-adjusted TKV. So at baseline, when we look at the total kidney volume and look at renal function, we see that some patients that have large volume kidneys also have diminished function, but then there is not a great degree of pattern that we can see here. Whereas when we look at it down the line, 8 years later, in terms of kidney function, we can see that patients that had larger kidney volumes tend to have lower kidney function. So at baseline total kidney volume, it can predict future relative decrease or future loss of kidney function. So it's It is predicting future loss of kidney function and not necessarily the current kidney function. So this is the gold standard of measuring total kidney volume, which is that we look at slice by slice or every other slice. We use a mouse and we kind of outline the entire kidney, and then we sum up the areas on the multiple different slices, and then we sum up those volumes to actually get the entire total kidney volume. Another way to approximate that, and this is a lot easier, is to use an ellipsoid formula, and I'm just going to take time on this slide because it's important and a good way of determining or estimating total kidney volume, and that is to take the mean measurement between the sagittal here and the coronal dimensions of the kidney, the mean of these two, and then multiply that by the cross-sectional measurement, the largest cross-sectional measurement. So then we have 1, 2, and the mean 3 dimensions, and multiply that by pi/6, and this gives us an ellipsoid volumetric volume. And this tends to do fairly well in terms of determining the total kidney volume, and especially the class of the disease that, the slide of which you just saw in the prior presentation. And then there are automated ways of measuring total kidney volume, and our next speaker is going to give us some beautiful insight into the different methods of doing this. So I won't spend much time on this as well. And just the final mention I'm going to say is that ultrasound does have a role in measuring total kidney volume as well. It's not going to be as reproducible and as accurate as using the different methods using MR and CT scan. But in terms of trying to determine who requires therapy and not, it does do a fairly decent job, fairly similar to ellipsoid formula for using MR as well. And I will stop right here. Thank you very much.
Thank you very much, Korosh. I just want to make one comment because you had a slide on the simple cyst, which had quite a lot more number that I would kind of expect. And I kind of wonder maybe these kind of patient we should restudy using the panel that look at the minor cystic gene. Maybe some of them are actually not so simple, but reflecting this kind of minor cystic genes. And I think this would be a kind of an interesting research question. I think we have a number of cases like that, that is more than like 5 cysts per kidney, that you kind of wonder whether they may have a genetic etiology.
Absolutely. I'm sure there's, on a day-to-day basis, we do tend to see quite a bit of variability in terms of cysts in patients who don't have kidney disease. And sometimes we do see that was a very prolific type example. So absolutely, it'd be very interesting to look at those. Thank you.
Thank you very much.